John?
Thank you.
I'm mindful I've overrun a little bit, so apologies about that.
I may have misunderstood, but misheard. I thought you said that the randomization visit happened at the time when you got the biomarker back. But you don't get the biomarker back. The result doesn't come, does it?
You don't get the result of the biomarker. No, you get. Francis will walk us through this in a minute. Actually, that's very much part of his presentation. Actually, hi.
Well, if I were a patient, I would really want to know the result of my biomarker. Is there a mechanism to tell the patient what the result was?
What, in due course, you mean, at the end of the study?
At the end of the study.
Yeah, I don't know that we've put that in place. It's perhaps something we could think about. Is there any reason why we couldn't let them know at the end of the study? Sounds like a good plan. Yeah, I agree with you, actually.
I want to know that.
People are curious, right? I agree.
Among exclusion criteria, you mentioned significant comorbidities as exclusion. What are we using? Just clinical judgment of ASA classification, just to formalize a bit more?
Your own clinical judgment as to patients you think would be reasonable to put into the study. Yeah, we don't want people who are going to keel over with, desperate illness later on.
Sure.
We don't want deaths in the study. That would be a bad outcome.
Miles, you mentioned anemia. Any objections to IV iron at the time of the infusion?
No. Normal treatments in all those regards. Yeah.
It's important to stress actually that we've tried to make this as pragmatic as possible. We don't want to be imposing on you as clinicians, a really weird and wonderful way of managing your Crohn's patients. So what we've given you here is the sort of the nuts and bolts of how we would like the study to be run, but there are going to be other parts of that, a la the what if your TPMT is knocked back, a la the do we use septin prophylaxis. All of those things we want you to just do as you would normally do. We don't want to start imposing weird or unusual things on this. This has to be pragmatic. We want this to be run in a pragmatic fashion, such that you are comfortable with the way that your patients are being managed within this study.
One important thing to say is that we're probably going to set up a little bit of a helpline on a Monday evening. So if people have got queries they want to phone into, James and I and Nuru and Francis will be there just to pick up any questions. If people want to just join in for the first couple of weeks they're running the study, you're bound to have questions. Things are bound to crop up and they're a bit of a discussion group, so please feel free to do that.
Again, older patients with heart failure, is it down to clinician judgment?
Yeah, down to clinician judgment, but again, if they're at significant risk of causing problems with anti-TNF or just dying of their heart failure, again, probably don't put them in. So healthy old people, absolutely fine in the study, of course. Obviously, the azathioprine may be a bit of a deterrent to you for that, in that regard, I suppose. Josh?
To those who are on the anti-TNF step.
So that's a really important point. Essentially, they go back to their normal care. Whatever you as a clinician were going to do to them, and there have been a few questions bowled at us already about, are you going to carry on funding anti-TNF at the end of the year? The answer is no. I'm terribly sorry. We're not going to carry on doing that. We're not committing to doing that indefinitely. It's an important point of interest, though, is, one of the questions is if you hit patients hard early on in their disease course, do you somehow affect their natural history of disease? So one of the points of interest as a follow-up study is going to be to see of the people who did stop their anti-TNF therapy at the end of the year, depending on which biomarker, part of the biomarker arm they were in, does that predict relapse subsequent to them coming off anti-TNF and so on and so forth. So there are interesting questions there, but no, it's over to you as a clinician to do what you choose to do at the end of that year. And that will be based on the endoscopic appearances and your general sense as to how severe their disease has been and so on and so forth, I'm sure. Yeah.
Of course, the point is worth making, though, that actually if a patient has been on top-down therapy, stops it at the end of the year, you might decide to keep them on azathioprine or not. But if they then have another significant flare-up, they're going to tick most of the boxes to at least, be considered for anti-TNF again, because they will have essentially had, combo therapy and, flared a short time after coming off it, even if you only chose to stop, one or other drug. So it's worth making the point, though, that actually many of these patients will meet the criteria to go back onto anti-TNF as per NICE, even if the anti-TNF is then stopped at the end of the study.
And the story data would tell you that they should respond nicely to their reintroduction of anti-TNF therapy.
Is there a follow-up to see what happens to them? Because that's really quite an interesting cohort, because you should see a difference between the high and the low.
You would hope so. So
in the following year as well.
There is a planned follow-up at 3 years after the study. It's not something that we're funded for, but we're very much planning to do that. So yeah, do please keep tabs on these patients. Simon?
One of the messages of the earlier session was that the disease has to be active for the biomarker to be work. Is there any sense in which you will know if it's not worked and say somebody's been recruited who's near the edge of this time window for active disease?
So yes and no. We get a sort of confidence score when we do the biomarker in terms of which subgroup they're in. There are things built in such that if we get one of the initial things, Nuru can correct me if I'm wrong, but we're actually taking 2 PAX tubes at the first screening visit, such that if the first one gives you an indeterminate result and it was simply something to do with the amount of RNA that we were able to extract from the sample or something on a technical level, we have the ability to repeat that immediately to make sure that it wasn't a technical reason why they were not able to be in one or other group. So far, of the people we've looked at, in all the validation work, we've not had anyone who we've not been able to confidently say is in one group or other. So we're not anticipating that we're going to have a big group of people who are somewhere in the middle, because the biomarker, as I say, everyone we've tested it in, it's been a very clear result that we've been able to then classify people with. But we're certainly factoring in the ability to at least repeat the test on in case of technical failure, as opposed to sort of biological not being able to put them in the right group.
Yeah. Are there biochemical criteria for when you can? Are the biochemical criteria for your biomarker like a high CRP number that the CRP has to be?
No. So basically, again, this has been, all of this work was done, work that I initially did in my PhD and then we've subsequently done since. And I spent the time doing exactly what Nuru is now doing, and which hopefully people in your centres will be doing, which is keeping your eye out for patients with newly diagnosed Crohn's. Now, when I was doing this, essentially, if the patient had newly diagnosed Crohn's and were off treatment, I put them in to the study. I didn't have a threshold for CRP. We had some people who, pretty much everyone's CRP was up a little bit, but some people it was 150 and other people it was 5. That doesn't seem to make a difference. It's just the fact they need to have active disease and be off treatment at the time they go in. But it's a great question. Okay, sorry. Matt. Behind you.
Can I just double check one thing? Azathioprine adjustments with regards to thyroguanine metabolites, that's absolutely fine.
Absolutely.
And infliximab adjustments with interval adjustments with trough levels, not
No.
so fine.
Not
So you're allowed the one-off,
yeah,
and that's it.
Yeah, and the one-off is we've specifically set the level very high. So basically, if you are not responding, you're pretty much guaranteed to be allowed an extra dose because of the fact we set the cutoff at 20 micrograms. But no, after that, no.
Okay. So
Simply because part of, as Miles said, the outcome we're looking for is steroid and surgery-free remission. We completely understand that in your practice, what you might do is double the dose of infliximab or check the levels or switch class of drug and everything else. That would make our outcome incredibly difficult to be able to assess. And so for a purely pragmatic reason, just for the year, it's just going to be, if the patient's flaring on anti-TNF and azathioprine, they get a course of steroid, they ding the primary endpoint, and that's essentially it.
So in these patients, the
diagnosed patients, so they should be fairly responsive to anti-TNF therapy.
Okay, but infliximab may have been the right drug for them, but just this trial might be that the wrong interval or dose. At the point that it's quite clearly wrong, are we pulling them from the trial?
If you feel, ultimately, again, this is pragmatic, right? So if you feel that your patient would be better off not in this study, then you're entirely, allowed to take them out of the study. That's fine. We're not going to impose that you don't. Obviously, if you do that, obviously at that stage the patient's not going to get anti-TNF through the study anymore. So it's entirely up to you, because essentially you'll then be going back to sort of standard care.
One, because we need to move on.
Yeah. Go on, Matt.
No,
you can ask.
So I was going to say, could we mix and match? But I suddenly realised they're not going to be appropriate for the statistical analysis. Full stop.
Yeah.
Okay, thank you.
Thanks. Okay, so we should move on.